welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello, everyone, and happy Monday. It's Dr. Mitzi, the Nerdy Neurologist. I am so excited to be here with you guys on another episode of Brain Chat, and I have an amazing guest, and we're going to be talking about, some of the earliest stages where we're trying to learn more about how people eventually become diagnosed with MS. So I cannot wait to get into it, but first we want to thank our sponsor, the National MS Society, for sponsoring Brain Chat, as well as the Joy Life Foundation. And of course, for those of you who are logging in live, I always like for you to log into the stream. Tell us where you're viewing us from. I bid you greetings from Atlanta, Georgia, where the weather was beautiful, sunny, and 60 degrees. And then tomorrow morning, it'll be 30. So who knows what's going on, but very, very excited to be here with you guys again today. And I am even more excited about my guest, who is here for her first episode of Brain Chat, but certainly is not a stranger to doing many medical presentations. She is considered a premier expert in our field. We have Dr. Jiwon Oh, who is the medical director of the Barlow Multiple Sclerosis Center at the University of Toronto. Welcome, Dr. Oh. Welcome to Brain Chat.
Thank you for having me, Mitzi. I'm delighted to be here.
Awesome. Thank you so much. It's so exciting to have you here. I'm glad we could finally get you on the show to talk a little bit about, what we're learning about the earliest stages of MS. But before we get into that, I became a neurologist because I just knew that it would be on the cutting edge of medicine, particularly with demyelinating disease and multiple sclerosis. When I first came to the field, we didn't have very many treatments, but I have been so excited to see everything change over time. So I always like to ask, what got you interested in neurology and what got you interested in neuroimmunology?
Neurology, I think it was back in medical school when we first started. I remember, having classmates who knew exactly what they wanted to do. And I was always a little bit bewildered because I was like, how do you know that you love the skin more than the bowels or more than the brain? But
Right.
the interesting part was, as you said, the brain is really the most complicated and most intricate of organ systems. And I would say it's, still a mystery in many aspects. And, in fields like MS, I think we're fortunate because we've made so much progress, but there's still so little that we understand about the brain. And so for me, that was kind of really interesting and challenging. And I think that's what drew me to neurology to begin with. And then with MS, I remember, when I first started neurology residency, I was all on board the stroke bandwagon because it was so exciting and all these things. But then I remember the first MS clinic that I did, and I met a patient who was really a similar age as me. And I remember thinking through all of the challenges that she was going through, being faced with this new diagnosis of a chronic neurological disease. And I really connected with that. And part of it was my mom had Takayasu's arteritis, which is a disease that's not that dissimilar from MS. It's an inflammatory vasculitis. And she, had a sudden stroke when she was 35. And I remember all those years of her struggling with this new kind of neurological state that she was in and being on immunosuppressants and all the specialists she would have to see. So I think it really kind of struck a chord with me. And MS is a pretty incredible neurological field where so much has changed and we've made huge progress. But then, the more progress we make, we realize that there's all of these unanswered questions. So that's a lot of information, but that's kind of how I found myself here.
No, I love it, and my thought process was similar, right? I loved the fact that there were things left to discover, right? There's still a lot to discover in many areas of medicine. But when I think about some fields, I'm like, gosh, they've got everything figured out down to the receptor, and they've got like tons and tons of therapies for this issue. And I really like the fact of the unknown. And like you, I did not have a personal connection to MS until after I chose to do MS. One of my family members was diagnosed, but I love the connection with the people, so people who were my age or a little bit older than me at the time. Now they're younger than me. But, I love the connection with my patients. I love that I can help kind of walk them through that journey and have that relationship with them over time. So those are things that really drew me into, the field of demyelination. So let's get into kind of, the meat of the discussion here. So, as I was thinking about this topic, we're talking about two things today. We're talking about the MS prodrome, and we're talking about radiologically isolated syndrome, which to me are kind of on the continuum of MS, right? So we have definite MS, clinically definite MS, where we know people have had multiple episodes of either neurologic dysfunction or multiple changes on the MRI that are consistent with MS. And then, we started to learn about clinically isolated syndrome, which was kind of pre-MS, where you had maybe one episode of symptoms and an MRI that's typical of MS. Now the question I think is, how can we catch people even before potentially they have that first symptom? And that's kind of where I think about the prodrome and radiologically isolated syndrome and kind of where those fit. So first, let's talk about what is the MS prodrome? What does that mean? And how would people kind of see that present in their daily lives or when they think back about their history before diagnosis?
So there's been a big focus on, as you said, Mitzi, kind of going back a little further in time. And this is because, as we know, when people present with MS symptoms for the first time, when we do additional tests like an MRI, it's pretty clear that something has been going on probably for many, many years. And so it makes sense that we try to rewind a little back in time to get a little closer to the onset of the disease. And, as you said, the MS prodrome and radiologically isolated syndrome, or RIS, are two kind of descriptions of, people that, do not yet have a diagnosis of MS, but happen to present. And so first, looking at the MS prodrome, this is actually something that was described by people looking at health administrative databases. And so, in many parts of the United States and in places like Canada, where there's kind of larger kind of central databases, when researchers have looked at people who currently have a diagnosis of MS, but they go back in time in the health administrative databases, they found some really interesting things, including that people who eventually have a diagnosis of MS, in the 5 to 10 years leading up to that first clinical presentation, they're clearly seeking medical care more. So they're seeing their PCPs because of kind of, what we often call as non-specific complaints, like, problems with pain in various parts of their body, problems with headache, depression. They're seeking additional medications to treat, certain symptoms like pain. And so these are the things that people have observed with the MS prodrome.
Yeah, and I think that's important because oftentimes when someone comes into the clinic, and they're newly diagnosed, maybe not that first visit, but maybe that second or third visit, they're like, oh my God, I've been thinking back. And, when I was a teenager, I had this issue or I had this issue. And so sometimes the symptoms seem like they're specific for MS, but sometimes they're not. They're not, I had this and this. Was that the MS? And I'm like, well, that doesn't sound like a neurologic issue. But it is very common that people will be like, I've had issues or I had these things going on for years and nobody looked. And so sometimes we're left to try to sort out, okay, well, that probably was your first episode of, demyelination, symptoms, but maybe these other things weren't, but go along with that prodrome of going to the doctor more frequently before diagnosis. So I think that that's really important. Sometimes we aren't always able to sort out one from the other, but important to recognize people are having those increased frequency of visits and increased things going on before they're diagnosed. Now, radiologically isolated syndrome, so the data about this has changed a bit over time, so I remember when the first papers kind of came out, we were like, oh, well, if someone presents, for some other reason, gets an MRI for a car accident or maybe for a headache or migraine, and it looks typical of MS, we used to say maybe there was about a third of a chance of them going on to develop MS. Tell us a little bit about first what radiologically isolated syndrome is, and then kind of what do we know about that person going on to develop multiple sclerosis over time?
Sure. So, similar to what we talked about the MS prodrome, RIS is, again, kind of rewinding a little back in time. And it's, there's overlap with the MS prodrome, but it is distinct from what is described with the MS prodrome. So, RIS, by definition, are people who happen to get an MRI for reasons unrelated to clear neurological symptoms suggestive of MS. So, Mitzi, as we always talk about in textbooks, there's these clear kind of neurological symptoms that most people with MS will initially present with, but it's very clear that, again, related to the MS prodrome, people probably have some vague symptoms beforehand that don't fit into one of these neat boxes. So
Mhm.
people with RIS are people who haven't had any of those symptoms, but they happen to get an MRI for a variety of reasons. Some of the most common reasons are they have, headaches, and so their PCP orders an MRI, or they have a family history of aneurysms and they get an MRI, or they happen to volunteer as a healthy control for an MRI study. And this has happened at our center many times because we're often looking for healthy controls for some of the MRI studies that we do. Anyway, so these are people that happen to get an MRI and they happen to have lesions, white matter lesions on the MRI that look exactly like what we see in people with MS. But they do not have any current or prior typical symptoms suggestive of MS. And so
Mhm.
that's what RIS is referring to. And that was kind of the initial description of RIS. And since then, there's been many studies done around the world. It's not something that's exceedingly common, but at any MS center or in any MS clinical practice, we all have like handfuls of patients who fit into this category. And so what we know is that, initially, as you said, the initial study said that at around 5 years, about a third of people will develop clinical symptoms suggestive of MS. Now they followed people for longer, and it turns out at about 10 years, about half of people with RIS will develop symptoms suggestive of MS. And
Mhm.
then there have been many additional MRI studies and other studies looking at people with RIS. And what we know is that um, it's pretty clear that they're on the spectrum of what we
Right.
think of as MS, because when we look at advanced imaging measures that look at whether there's brain atrophy, whole brain, or thalamic atrophy, whether there's changes in myelin content in the brain based on some imaging measures that are more sensitive to myelin, when we look at things like the central vein sign and the presence of paramagnetic rim lesions, people with RIS have all these findings. It's just to a lesser extent than people with established MS. And then the other
Mhm.
thing is when you use kind of fancier clinical tools to look at people with RIS, and when you do scales looking at fatigue and depression and quality of life, it's very clear that people with RIS have subtle symptoms. They may just
Mhm.
not be these very typical clear-cut symptoms that we think of in people with clear MS. And so,
Mhm.
for instance, there was a study where they looked at these fancy engineering gloves that are able to detect subtle signs of issues with coordination and manual dexterity. And it's very clear that people with RIS, compared to age-matched healthy controls, have evidence of subtle deficits. It's just that
Mm.
it's not so blatant, and so they
Yeah.
probably may not even realize it. So that's what
Yeah.
RIS is. And the bottom line is with RIS, the more evidence that accumulates, the more that it's clear that it really is in the spectrum of MS. It's just
Mhm.
not, it's just that people don't have these, blatant relapses or these very clear cut symptoms, again, that we think of as textbook MS symptoms.
Yeah, I mean, so much amazing information in what you said, and I think that this is really important because I recall a time, during my training when MRIs were a little difficult to get, So if you ordered an MRI, you had to have a darn good reason, and getting them as an outpatient, they were very expensive, So there was limited access, I think, and maybe maybe we weren't seeing these changes as much, unless they were done in research studies. Now it is a lot easier to get an MRI. And I have people that get MRIs, not because they have symptoms, but they may be concerned, that a family member had an aneurysm and they want, to get checked out, or, they may have some vague symptoms. And so, I certainly have seen, a handful, as you said, of people who've come into the clinic that have gotten MRI for some completely different reason. And it looks exactly like MS. And when we try to go through the history, some of them have no symptoms that we can report. Now, I don't have fancy gloves, here at the clinic. Certainly with some of those finer tools, we can find these things. But I think it is important, for people to know that if they do have those changes, at least, they need to be following up with a neurologist and not ignore it. Let's take a step back and let's talk about what the white spots on MRI mean, right? So I do also, and I'm sure you as well, get many patients who have gone to get an MRI for some other reason, and the word demyelination is mentioned in that report. So when we're looking for things like radiologically isolated syndrome or signs that are suspicious of MS, what are we looking at when we're looking, or what are we looking at when we're looking at those white spots? What are kind of the characteristics that may lead us more toward, a diagnosis leaning toward MS, or maybe more away from that?
Yeah, so I think, you're kind of getting to a really important point, Mitzi, that I don't want our listeners to think that anybody with any white matter spots on an MRI that they happen to get has MS, just
Right.
because there's many, many different reasons why people can get little lesions in the white matter. As people get older, people with different vascular risk factors, even people with just, routine migraines can get
Mhm.
these. So just want to put that out there, that I don't want there to be mass panic that just because
Oh
there's,
my
you have MS. But,
Right.
MRI is obviously a really useful tool, but I think we
Mhm.
need to remember that clinical judgment is always paramount. And there's a certain way that lesions related to MS look on the MRI, and we have specific criteria that help guide us. And so, for instance, most typical MS lesions should be a minimum of 3 millimeters in size. They're
Mhm.
often ovoid. They're often well circumscribed, and they're often
Mhm.
in very typical locations in the brain as well as in the
Mhm.
spinal cord. And so I think before kind of willy-nilly applying kind of, some of the MRI criteria that we have that are suggestive of MS, we always need to keep in mind that we need to use clinical judgment and also
Absolutely.
radiological judgment when it comes to looking at white matter lesions, because again, people with migraines can get just these tiny little white matter lesions, but they do
Mhm.
not look like, and they are not in the typical regions that we see usually lesions in MS. And so some
Yeah.
of the regions in the brain, this is getting a little technical, are,
No, go ahead.
periventricular lesions, which are near
Mhm.
the fluid cavities in the middle of the brain,
Mhm.
juxtacortical, so near the gray matter, in the infratentorium, which includes the brainstem and the cerebellum, and then the spinal cord. And again, there's these kind of characteristics that the lesions have that make an experienced neuroradiologist or neurologist think, that looks like a lesion that is suggestive of MS. Whereas some
Mhm.
lesions you'll take a look at, and when you've seen enough MRIs, you know that, there's often lesions that we call non-specific that don't really raise the concern of MS.
Yeah. And I think that, again, that's important because I do have many people, obviously, our MS population is often very educated. They're very well read about their condition, but I've got those who, try to read their MRI reports and interpret those reports. And they come in very frightened that they have this condition. And when we look at the, MRI, I'm like, this doesn't look like what we're dealing with. The way I usually explain it to people is the only way to tell what a lesion is 100% is to do a biopsy. But since we're not routinely doing brain biopsies, we look at where they're located and kind of how they look to try to determine if we think they're correlated with one disease versus another. I think another thing, obviously we're talking about brain MRIs, is that also imaging of the spine can help us, because if there are lesions in the spine, that's a little bit more specific to demyelination. You don't typically see migraine spots in the spine. You don't see those vascular changes as we age show up as lesions in the middle of the spine. So that sometimes can help us to differentiate if we think, there's something, going on in the demyelination category versus the other. And this is another question. That's a little bit of a curveball, but not really. Have we seen any prodrome with any of our other demyelinating diseases, right? So typically MS is the most common, but we do have other conditions like NMOSD, neuromyelitis optica, and now we're learning more about MOGAD, anti-MOG antibody disease. Have we seen any evidence of a prodrome with those conditions, or is it just really isolated to MS?
I mean, I haven't seen any literature on the prodrome with those conditions, but I think it would be a really interesting question to ask. And
Mhm.
particularly with a disease like MOGAD, I think, with all of these other neuroinflammatory diseases, we're learning a lot, and the way we look at the disease has changed a lot in the last 10 years as well. But with
Absolutely.
diseases like MOGAD, I think there is much less of a chronic component in comparison
Mhm.
to diseases like MS. And so I wouldn't be surprised if, say, with a disease like MOGAD, there wasn't as much of a prodrome as there is with MS. But of course, we'll need data to prove that.
Absolutely. And the difficulty is those are obviously, I mean, MS is considered a rare disease. We know now nearly 1 million people in the US have MS, but 1 million compared to our population is a small number. But certainly with those diseases, they're rarer. So, it can be more difficult to get data on the same scale as we have with MS. So when we think about, kind of CIS, which was, what we kind of considered pre-MS, one symptom, plus an MRI that looked typical of MS, at least one lesion. Many of our medications are now indicated to treat CIS, whereas at first you had to have definite MS. Now we kind of move the needle back to treat CIS. What do you think? Will the needle move back to treat RIS, or how do we treat RS? Do we treat it or do we just monitor it?
So, for in the last 2 years, we now actually have two clinical trials demonstrating that two of the oral therapies that are used in relapsing MS, DMF and teriflunomide, are effective at reducing the risk of RIS converting to MS. And so
Wow.
I think we, are starting to get very good evidence that some of the therapies that we use in MS are effective for RIS. And again, this kind of gets to the point that RIS is very clearly in the spectrum of what we think of as MS. But in terms of what is typically done in clinical practice, I think, that change still hasn't yet occurred. And
Yeah.
probably in part it's because it always takes a while for evidence from clinical trials to be approved on a practical basis so that
Mhm.
neurologists seeing people with RIS can actually prescribe these medications. And so I think it depends on what part of the world you're in. But right
Mhm.
now, in Canada at least, we don't have a Health Canada indication yet for RIS. They have to
Mhm.
have MS. And so
Yeah.
I think it really depends on where you practice and kind of, how you interpret people's symptoms when people with RIS say, have these vague symptoms that are not typical of MS, but whether you would actually label that as MS or not.
Mhm.
But I think it's very clear that the field is evolving to understand that, again, MS is a disease spectrum, and we actually have a revision of the diagnostic criteria that's going to be
Mhm.
reported this year. And so that specific question was visited at that meeting, looking at RIS, like very clearly, these are people that, again, based on the studies that I, discussed earlier, they have lesions that look really similar to what we see in people with established MS. And when you use all of these kind of fancy clinical tests and imaging measures, they're not really that different from people with established MS. So the question of
Mhm.
whether we should include RIS in the diagnostic spectrum is a very relevant one, and I think
Mhm.
we'll be seeing some changes coming up.
Mhm.
And then that obviously opens the door to treatment for these people.
Yeah. And I think, part of the difficulty is, with CIS or clinically isolated syndrome, there was a feel that, okay, 80% of these people are going to go on to develop, 80% or more. So you feel kind of confident with those odds if you're looking at a young person and preparing to put them on medicine that is going to interfere with their immune system for the rest of their lives, right? And then when you look and you go a little further, say a third, it's like, I don't know if those odds are, and then when you look at, the person sitting in front of you, some of them are like, well, I feel fine. If you can't kind of guarantee that I'm going to go on to develop MS at this point, then I don't know if I want to, consider going on treatment. I do know of some colleagues, who see if patients come in and they have, repeat MRIs and maybe new lesions, or particularly those lesions that are active and inflamed and lighting up with contrast, they will, kind of counsel people to consider starting treatment. But I think, it's kind of difficult. The treatment buy-in, so to speak, can be a little difficult for a young person who feels well after a relapse. So someone comes in, say you've got MS, they had something and it got completely better, they may say, "Well, I don't wanna do anything, I feel fine." So to try to back that up before they actually have a symptom, I think in some cases might be a little bit more difficult. What are your thoughts on that?
I completely agree with you, Mitzi. And I at our center we have a really large MS center where we follow almost 10,000 patients, and we've kind of collected a cohort of people with RIS that we followed now for almost 8 years. And I got to tell you, like I see a lot of these patients, and it is a hard sell. And to be honest, I don't blame them because, like you
Yeah.
said, yes, the longest studies that we have are over a decade. 50% of people will develop MS, and
Mhm.
but 50% don't, and
Right.
there clearly is a population of people that will remain stable even when you monitor them with MRI every year. There's, clearly people who don't develop any clinical symptoms, don't have any clinical symptoms, and then don't even develop new lesions on MRI. And so it's a tough sell. And I think this is an illustration of why we need better prognostic markers because, and
Mhm.
this applies to really, really early MS as well. Obviously we're in an era where we have tons of treatments, and we know that in people with active disease we absolutely need to start treatment early and
Right.
optimize treatment quickly. But then there is this small proportion of people who have very, very mild disease, and it's
Mhm.
relevant to this discussion of RIS. So clearly we need better ways to achieve optimal personalized medicine, and this is
Yeah.
relevant to RIS. So I agree with you. First of all, it's a really tough sell to tell
Mhm.
someone who's feeling fine, who happen to get an MRI for usually an irrelevant reason, and telling them that they need to be on some chronic therapy that might make them have really annoying side effects.
Mhm.
That's tough. And I would feel the same way if I were in the boat. So clearly, we need to do a better job in the field of deciding who needs to be on treatment and who needs to be on treatment early and who needs to be on
Mhm.
what treatment. But as a blanket rule, I think it's always erroneous to think that everybody with something absolutely needs to be treated. And that's
Yeah.
not the case here, but we just need better ways to figure out who does.
Yeah, I totally agree. So MRI has kind of been our hallmark, but MRI only tells us so much. I look at it like the difference between having a mirror in your bathroom and then going to a really nice hotel and having one of those mirrors that shows 10 times the magnification. So there's a certain level of detail you can see in the bathroom mirror. You can see it, but if you have something that shows you a lot more detail, then maybe there are other subtle things that we're able to see that may help direct treatment options or, our conversations about treatment.
Yeah.
And with that being said, I want to talk a little bit about some of these MRI techniques. Now, you alluded to them, right? So when I give that analogy to people, they're like, okay, I understand it, but when are we going to have the 10 times magnification MRI, that can tell us all those details? So I'm really excited about some of the new MRI techniques that are primarily being used in research, but how they may help us to better understand how people are doing over time and help us to understand about people's prognosis. One of the biggest issues we see is progression, right? People that come in and say, hey, Dr. Mitzi, I'm getting worse, but their MRIs look the same, right? Now we're talking about smoldering MS, the inflammatory process that goes on inside of the brain that's kind of separate, from the peripheral process that we use most of our medications to treat. So what are some of the MRI techniques that you are excited about that are potentially, probably a little ways away from being at every radiology area down the street, but that can really help us to understand what's going on under the surface with people's MS, in the absence of them actually having changes in their symptoms?
So, there's, you already hinted, Mitzi, at one of the major issues with some of these fancy MRI measures. When they're
Hmm.
too fancy and essentially not accessible, they're not useful clinically because this is the thing. And, I love having research MRIs and getting to play with all these different techniques, but I'm also a really practical person at heart.
Hmm.
And
Hmm.
I know that unless a technique is very easily accessible and widely available and easy to obtain a relevant measure from, people will not use it. Like
Right.
clinics are crazy busy, as you know, you're trying to get through a million things. And can you imagine having to like process MRIs for some fancy measure to get some fancy number that you may not know what to do with? And so
Right.
based on all of this, there's two techniques that I'm really interested in and excited about, and it's because they kind of pass that practical test. And
Mm-hmm.
one of them, relevant to our discussion about RIS, is something called the central vein sign. And what
Mm-hmm.
this is when you use an iron sensitive MRI sequence, and there's a bunch of them that can be useful, but there are certain sequences that are better than others at looking at this. In white matter lesions, if there is a central vein, you can see it because a vein has blood in it, which has iron in it. So this is why you need an iron sensitive sequence. And the reason we care about this in MS is because we know that the pathological hallmark of MS white matter lesions is that they formed because of perivenular inflammation and demyelination. So if you see this central vein in a white matter lesion, the likelihood that it formed related to MS is very high. And so
Mm-hmm.
the reason why this is interesting is because, you know, like we talked about earlier, there's many reasons why people can get white matter lesions, but if you had an MRI tool that's easy to obtain, that can tell you whether a white matter lesion is related to MS, think how useful that would be from a clinical standpoint, because it would help us diagnose people with MS faster.
Yeah.
And importantly, it would prevent misdiagnosis, because
Yeah.
misdiagnosis, you know, we all pride ourselves, I think, on our clinical judgment, but you know, we make errors. And when you
Absolutely.
look at the rate of misdiagnosis, it's up to like 20 to 30% in even
Mm-hmm.
MS specialized centers. So this
Yeah.
is a tool that might make it into the clinical realm because it's easy to get, it's practical. You know, certain MRI vendors are not allowing access to some of these iron sensitive sequences, but there's a lot of pressure right now. And if it becomes part of the diagnostic criteria, it'll likely be part of the commercial MS protocol package.
I
And
love
so
it.
that's a tool I'm really excited about because it can help to make a diagnosis of MS, which we know is very important because
Mm-hmm.
it helps us with treatment. Now
Yeah.
the prognosis piece is a challenging piece, and you know we have all these tools that we use now, like you know clinical features, having a high baseline MRI lesion load. These are all things that we use to prognosticate, but let's face it, those factors are all kind of crude, right? Because
Yeah.
not everybody who is a guy will do worse than you know women with MS and all of these.
Right.
So so there's tools that are on the horizon that may make it into clinical practice again soon because they're pretty practical to get. And one of them is something called paramagnetic rim lesions, or
Mm-hmm.
PRLs, which probably
Mm-hmm.
a lot of people have heard about. And it actually,
Pearls.
pearls,
We love
exactly.
a good acronym.
So, you know, to get to look for pearls, you use the same iron sensitive sequences that you use for central veins. And around some chronic lesions, if you see this rim of iron, it means that it may be due to a rim of activated microglia, which cause smoldering lesions. And you know, we've heard the term smoldering a lot, but essentially what this refers to is within the brain, there's all of these chronic kind of inflammatory smoldering processes that we think are relevant and drive
Mhm.
progressive disease biology. And so
Mhm.
basically, if you see somebody with a lot of pearls, the likelihood that they have more disability is much higher. The likelihood that they have progressive disease is much higher. And probably from the very beginning, if somebody has a lot of pearls, that is not a good prognostic factor. So this
Right.
is an example of maybe a tool with more validation that
Mhm.
may be useful in the very near future to help us prognosticate better and to understand who needs to be on certain types of treatment more quickly. And it may also help us to monitor progressive disease biology as well.
Yeah. And I think, those are excellent points. We talk about these a lot at our neurologic meetings, but, again, I agree with you. It has to be accessible. It has to be something that we can look at in the community to really help the large majority of people with MS, because the majority of our patients are unfortunately not able to have access or qualify for certain clinical trials. And many of them are treated in the community, so we need tools that are present in the community to kind of help guide how we're adjusting or changing treatment over time. The the other thing that I'm going to ask about is the role of AI, right? So, there's a lot of talk about AI looking at measures of atrophy, so shrinkage of the brain and how we monitor that over time. We know that, atrophy of the brain can be related to things like cognitive problems or other issues later on with MS. We know the brain shrinks over time as we get mature. I say mature instead of older, although they're not synonymous. As we get older, the brain shrinks, right? And then you have the MS causing increased shrinkage on top of that. Do you think that, some AI techniques may make it, to the mainstream as well that can help measure that shrinkage over time? Because when you look at it, I'm looking at an MRI. I always compare one MRI to the previous one or maybe the previous two, but I may not go back to the one 10 years ago. And if I look at the one 10 years ago, there may be a subtle difference, that I can't really catch or that maybe the neuroradiologist can't catch with just a naked eye.
I think there's a huge role for AI potentially in not just MS, but in medicine in general.
Yeah.
But some of the challenges with using AI is that sometimes, because that's the whole premise of AI, it's like you feed a ton of data into these vast computer systems, and it evaluates all these patterns that we may not be able to see, and then kind of based on a ton of data gives you kind of an answer.
Right.
And I think there's a real attractiveness to that, because I think we're living in an era where we have so much data that it's almost difficult to know what to do with it, particularly in a scientific field. But the issue with that is that I think it still needs to be understandable to clinicians, because I think we would all feel very uncomfortable if we just threw in like all the MRIs that someone has, and then suddenly the computer tells you this is the treatment someone should be on. And then I think, I maybe call me old fashioned, but I would feel a little bit uncomfortable with
I'm
that.
definitely old fashioned. I'm not going for it.
Self-driving cars either, so
Not yet.
I think
I'm not ready.
the bottom line is we need a lot of data. We need to validate these measures. We need to understand what the AI algorithms are using to generate these kind of medical decision points. And when that all comes together, and we know that there have been many training data sets used and that it's valid across many different populations, because as you can imagine, people with MS living in Toronto are probably very different from people with MS living in Atlanta, for instance, different parts of Europe. So I think we need to be reassured that these algorithms work, across many different MS populations. And then if they make sense as well, I think there's a lot of potential for it to be time saving and for us to use it. But there's all these steps that need to happen before that. And again, maybe I'm being old fashioned about it, but I would want to see a lot more data, and I would want the AI to be explainable to me. And then if that makes sense, then I would be very happy to use it as a tool in clinical practice.
Right. So what I'm hearing is very interesting, not ready for prime time potentially. And, I would agree, because the difficulty is you get these numbers, but what is the threshold to make something actually meaningful, right? So if you give me, you put everybody, if I take a patient's MRIs, I put them all in the computer and they say, well, the brain shrunk this percentage, right? How does that translate to how that person looks or how I would expect that person to feel? Or does that mean I need to change their medicine? Or, so I think there's still a lot that we need to discover, but I'm still always very excited because we're learning so much, and I feel like, neurology is the cutting edge of science. Like there's always some new discovery. Almost every year there's some breakthrough and we're like, oh my gosh, this is so cool. So that's one of the things that I love about it, and I love about the field with MS. So, that went by really fast. Our time is coming to a close, if you will believe it. But I always like to ask, what are you excited about in the field of neuroimmunology? Like what kind of breakthroughs or other things are you personally excited about in the field?
Well, there's always so much, it's hard to pick, but I would say, like, just kind of looking at the immediate future, I'm really excited about the diagnostic criteria revisions, because I think that it's kind of a big change, compared to before. And I think it really tries to incorporate all of the emerging science in a rapidly developing field like MS. So, to be able to kind of harness all of that and try to like trickle it into these diagnostic criteria is obviously a challenge, but I think it's such a reflection of the fact that our field understands that things are changing rapidly. And so, clinical guidelines also need to change accordingly as well. And so that's one piece that I'm really excited about. And then another thing is, new therapies. And I know that
Yeah.
many people were disappointed with the BTKI results of
Mhm.
evobrutinib. But I think there is tremendous potential for this class of molecule in the field of
Yeah.
MS because we're trying to get at that CNS compartmentalized smoldering inflammation. And so, some of the early data look really good, and some of the
Mhm.
animal data and the lab data look really good. And so, I'm really keeping my fingers and toes crossed that this
Yeah.
year we'll have some clinical trial results that we can tell, people with MS about, and for the first time to be able to say, hey, this is a drug that actually gets into the brain and
Yeah.
really modify some of these chronic smoldering processes that we know are causing smoldering disease that we see in most people with MS. I mean, that would be a breakthrough. So I'm really
Yeah.
hoping and keeping my fingers and toes crossed and excited about it.
Yeah, me too. So I am always excited about therapeutics and new therapies, but particularly when there is some new mechanism or something that could really, change the course of disease, right? Because we talk about how our medicines slow progression, but they don't do a great job of slowing progression, and there's only so much progression you can see in our clinical trials, which are a year or 2 years, so I think that those are very important. I also have my fingers crossed that thing will have a positive trial from one of these agents. I think the thing I'm always excited about is kind of the aspect of looking at lifestyle medicine. I'm very interested in integrative medicine because I think earlier on in my career, we were so focused on stopping relapses and preventing new MRI lesions that we really didn't have time to focus on lifestyle, because it was like, okay, well, we got to, make sure we're monitoring this medication, and we're still doing that. But with our more effective therapies, we're able to do that, I think, a lot earlier on in disease. And so now we can say, okay, well, let's focus on brain health. Let's talk about exercise. Let's talk about decreasing stress. Let's talk about all these other things, and let's learn about them, in a scientific manner instead of telling somebody, okay, just eat right and exercise, and they have to go figure out what that means. So I'm really excited about that, but definitely excited about many of the breakthroughs that we're seeing, and excited about the research that you're doing. Thank you for everything that you're doing. I've always admired your work, particularly looking at RIS and the Prodrome. You guys have a large population, and you're really helping all of us to inform our patients about, pre MS potentially. So thank you for everything that you're doing. And that's a wrap. We have finished this episode of Brain Chat. It's been an amazing discussion. Thank you again, Dr. O, for coming on and sharing your expertise and your knowledge. And for those listeners, thank you all for tuning in to Brain Chat. We will see you again in 2 weeks. Thank you so much.
Thank you, Betsy.